Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome once again to Health Matters, a comprehensive chat by the Islamic Medical Association, Muslim health professionals trying to empower you, educate you, and provide a service. And through this forum, again, expanding the knowledge to our viewership on various medical matters. Tonight's topic is that of urology, and we welcome Dr. Salim Choonara, a urologist in private practice in Johannesburg. Assalamu alaikum, Salim.
Wa alaikum salam wa rahmatullahi wa barakatuh, Yakub, and to the esteemed viewers of ITV.
Alhamdulillah Rabbil Alameen wal aqibatu lil muttaqeen. As-salatu was-salamu ala ashrafil mursaleen Sayyidina Muhammadin wa alihi wa ashabihi ajma'een. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Allah says in the Quran in verse 51, ayahs 20 to 21, where he says, in your earthly environment there are signs of the different domains of knowledge. Within your persons there are signs and pointers and guidelines to the different facets and dimensions of knowledge. Would you not engage yourselves in observing the signs of Allah and the cultivation of knowledge that is connected therewith? And I've quoted this from Fazlur Rahman Ansari's book, where he says that we have been told about two levels of knowledge. One, knowledge of oneself and that of the environment around us. And again, we reflect when we talk about urology and the different parts of the body as we're delving through the health matters week in and week out. Again, we marvel at the normality which Allah has created, and also when there's deviations from that norm and what happens. And we are asked to reflect, and again, we are looking at the environment in this particular regard, but we also look at ourselves and the body in the physical format, but at the same time, we reflect spiritually on it. So we will again be given different examples of what happens to the kidney and the prostate and various urological anatomical parts, as Salim will expound on them, inshallah. So Salim, we'll start now today discussing urology, which is your field. But what happens to us in GP practice, patients come to us and they say, we went to the kidney specialist, or we'd like to go to the kidney specialist. And they may be referring to you or to the nephrologist. And I know there are definite elements of overlap, but sometimes the lines are blurred. But then again, there are areas of distinction.
That's right.
So perhaps maybe you can just go through us and tell us what is urology and explain that in simple terms. Sure. And then we will then explore further.
That's a very good point. And often you end up, something with patients coming into your rooms and you're looking for the nephrologist, and ended up with the urologist. But essentially, there is overlap because both specialties deal with the kidney as a major anatomical source. In urology, it's the study of the urinary tract. So that does not only include the kidney, but includes the kidney, the pipe between the kidney and the bladder called the ureter, and obviously the bladder. In the male, the prostate as well, and the genitalia in the male. And obviously, and this is across the board, both female and kids as well. The difference with nephrology is it's more dealing with the medical conditions of the kidney. So often people that have renal kidney failure, a disease of the kidney such as glomerulonephritis, hypertension, diabetics that suffer with kidney disease, those things are more dealt with the nephrologist. Urologists deal with the surgical complications of the urinary tract. So any cancers of the urinary tract, stones of the urinary tract, any anatomical abnormalities that need to be surgically corrected, if I could summarize it in that way, is dealt with by the urologist.
So slide 1 could come up, and perhaps we'll be able to see the anatomy, and that will kind of explain the various parts of the body and the system we're talking about. Do you want to maybe just go through that, Salim, and just explain what we're seeing there on the slide?
Absolutely. If we look at that slide, to the left of the slide, left corner, that would be the bladder. Just below the bladder sits the prostate, and to the right of the prostate is the rectum. And if I could just bring it up here, often this is the thing that men don't want to come for, is a rectal examination. But you can see the proximity of the rectum to the prostate, and hence the easy access in terms of examining the prostate via the rectum. So that helps to identify that as well. But we can clearly see that the prostate sits just below the bladder, and the urinary pipe, in other words, the pipe that carries the urine out of the bladder, it has to traverse through the prostate. And so when the prostate enlarges, one can understand why men are likely to suffer urinary problems, because that's exactly the route that the urine has got to take.
So that's a good starting point, because we're looking at the prostate, we're talking about men's prostates becoming larger at a certain age. Obviously, with time it increases, and that's one of the most common conditions you see in the male, in urological terms, is the growth of a prostate condition which we call benign prostatic hypertrophy. And that would be perhaps a good point to start with in discussing that condition as we delve through the urological system.
Of course. You're right. Men only realize that they have a prostate at probably age 50 when they start experiencing some symptoms and issues with urinating. And often those symptoms would include things like they would say that I got to go very often to toilet, I wake up a lot at night to go to toilet, I have difficulty urinating, I got to strain, I got to push a lot when I urinate, I got to strain, or I find that there's a long delay before I actually am able to start urinating. And also often they say I got to spend a lot of time in the toilet, and often the wives will say the husband's in the toilet for such a long time, what's going on? But these are some of the realities of the issue, that they take longer to empty their bladders, and sometimes they don't even empty their bladder. You find that they urinate, and in a short while they got to go back again to toilet, what we call frequency. So that's probably the initiating factor, or the initiating symptom that will make a patient come to the urologist or go to their GP first and seek some medical assistance. But up to that time, I don't think men realize that they only have a prostate and it's not found in a female. So yes, that is the most common diagnosis that we see.
Now, look, a lot of those symptoms also occur in diabetics, right? Frequency of micturition and getting up at night, especially when they're uncontrolled. So the first port of call would be the GP, and then he'll then obviously differentiate, try and exclude diabetes, and then perhaps refer to you, right? So do you see sometimes that patients come to you and then they have both conditions occurring together, yes, and then there's a bit of confusion with the symptoms?
Absolutely, that's a very good point. Obviously, when they present to you, they present you with symptoms. The clinician or the GP or the specialist, whoever is involved there, it's for them now to decipher what the cause of those symptoms are. And as you just rightfully said, that there is overlap of other conditions that can give rise to similar symptoms, such as diabetics. Clearly, infection itself can just do that. A simple prostatitis or an infection of the prostate, which we'll touch on a little bit later, can certainly also present with symptoms similar to that. And obviously, in those patients that have abnormalities with their bladder, that have neurological problems with their bladder. So people that suffer, that had a stroke, or they have muscular sclerosis or muscular dystrophy, any of those neurological conditions can also present with urinary symptoms. So you're right, the port of call would be the doctor, the GP, the specialist, and it's for them now to go through a series of tests and assessments to decide, what is the cause of those symptoms. Yes.
So the BPH we're talking about, so when they come to you now, you're suspecting BPH, what kind of simple tests do you do before you make that diagnosis? And then, of course, then we can discuss some kind of management and treatment.
Sure. That's very important. In medical science, we often thought, and I'm sure you remember the medical school days, thought about history taking.
Yes.
And that's the key factor. That always starts off with that. And we make sure we take a good history, expand on the symptom that the person is describing to you, and you want to get a bit more detail and ask the relevant questions. Once we've done with the history, we want to go through other medical conditions that they may be suffering, such as you mentioned diabetes. Can that be the cause of what they're experiencing? And other factors. And then once we've done the history and we're happy with what we've taken, then the next thing is to do an examination. And the significant part of the urological examination, especially with reference to the prostate, is the rectal examination. And a lot of males prefer not to come to the doctor because they don't want to have that test done. They prefer just to do a blood test, which we'll talk about. So the rectal examination is very important in this situation, especially if we're dealing with the prostate, because that's the only way we're going to know what is wrong with the prostate. Is it hard? Is it got nodules? Is it just a soft prostate? Is it enlarged, etc.? You can only have that impression when you have a tactile appreciation of the prostate. So once you've done that, and then as part of our assessment in a urological practice, we do an ultrasound as well. So we're able to decide on, measure the prostate. We can have an idea about how much volume is in the bladder when the person, before they urinate. And we get them to urinate in a special type of machine called a uroflow that gives us an objective assessment of the flow rate. How quick, how slow are they actually urinating. After they urinate, we then check with the sonar again and see how much of urine stays behind. So putting all that together gives us an idea that, okay, this person came in, they got symptoms, they complain about difficulty urinating, they're struggling, they're having about a frequency, they're going often to toilet. On examination, we find an enlarged prostate. We did ultrasound, it confirms that. We measure the flow, we find it's restricted. We check the bladder again, we find it's not emptying correctly. We sort of put everything now, everything is in line to say, you know what, you've got a large prostate, it's causing a narrowing or an occlusion to the urinary tract or to the pipe that carries the urine. And as a result of that, you're having difficulty and also you're unable to empty the bladder. So that would be almost a logical approach to saying this person has got BPH or has got an enlarged prostate. I just want to be hesitant to say benign prostatic hypertrophy just yet, simply because at that point in time,
you still don't know.
We don't know.
Yeah.
We know it's a large prostate,
Yeah.
but we don't know whether this is related to just a benign enlargement, in other words, it's nothing to be concerned about, or whether or not there's an underlying malignancy or something else that we need to be concerned about.
Yeah, we're going to get to that where we're going to make the differentiation. So, okay, once you've established that it's benign, obviously we're going to talk about the malignancy. The patient is obviously uncomfortable. He's getting up at night, he's going often to toilet, his quality of life has been impaired and been disrupted, right? So, and in the older days, I know that it was surgical management. Okay,
That's right.
Today medicine is advanced, and we can now manage them more conservatively with a medical type of management.
Absolutely.
So, what are the options? When would you do medical management? And then, what is the last option? Obviously, surgery. And under what conditions and circumstances would you then institute that management plan?
Right. Yes, that's a good question. Medical management would obviously be the first line of treatment. Surgery would be something that we would want to use in somebody where we've tried medical therapy, it's not working, and they're still having symptoms, and we would consider surgical. But to expand on the medical option, medical therapy involves using, obviously, medication, tablets. You've got to drink some tablets, you've got to take a medication on a daily basis. And something that becomes also a bit stressful for the patient, because they may have to be on this medication for an ongoing period, maybe for a year, maybe 2 years, maybe even longer. You get some people that are on medication for up to 10 years. So it's a daily dose. It's usually a daily dose for the more common type of medication that's available. And what the medication does is it helps to relax the prostate and the bladder neck. So it allows your urine to be more freer. So you're not straining. So it eases the flow. And often in those patients that it works, it actually works very well. And that's the reason why they stay on it for a long period of time. There's one class of drugs which we use. There's different types of names, and I'm sure those that are on treatment will have a varying idea of what they may be called. But they have a similar type of makeup or ingredient that one uses. There is a place for combination treatment. So initially it would be monotherapy, meaning a single agent, one drug.
Yeah. Right. Okay.
In patients that are on what I usually do in my practice, I mean, they would probably be on it for like a period of 6 months. 3 to 6 months, and let's see how they're doing. If they're responding well, we'd like you to continue with that form of treatment. But let's say they come in, they say, look, you know what, there's really not much improvement. Before we just opt for surgery, one has the option of exhausting the medical route, and that may
like a second line of treatment.
Correct. So we could probably add some medication to that. Okay. It's a different type of agent, but it works on almost causing the prostate to shrink a little bit. So the two together may also help to enhance the flow and make them feel better. Remember, when you say who do we decide to give medication to? It's very simple, because we have to decide on how much these symptoms are affecting the quality of the life of the patient that's in front of you. And we have a certain scoring system that we use to decide that, and based on that, we know how severe is this to the patient. I mean, if they're waking up for 3-4 times at night, when do they sleep? Their quality of life is impaired, their work is affected, or they can't even travel, they got to use the toilet all the time, etc. So, one is to gauge it as an individual and decide on that what the extent of treatment is likely to be.
So it's individualized treatment based on the patient's symptom score. Yes. Patient will tell you this is what's happening. You ask him very specific questions about the symptoms that are related to the condition.
That's right.
And then you got one drug as the first option, and then you got a second one which may potentiate the effect of the second one, and then help. And then obviously once you reach a certain limit where neither of them are providing the relief that you are targeting or trying to achieve, then you can then go to the surgical side. All right. But now you just backtracking a bit, you mentioned that they're going to be on this for a long time, right? And that can be a negative sometimes in patients who find compliance an issue. And you get patients on high blood pressure tablets, and usually in that age group, they're already on some high blood pressure tablet or a diabetic thing, and then suddenly now they have to add another one. So a lot of education is required to tell them the benefit and to try and delay surgery as much as possible. Is that correct?
Absolutely. You raise a very good point that often patients at age 50, 55 or 60, they most likely have some other comorbid disease, maybe hypertension, diabetes, etc. In a way, they're kind of used to taking medication, so this is not a very new system for them, so they may be able to adjust to it. But equally well, you'll get people that just will not be able to handle that, and they feel like it's just too much of medication. The good thing, I must say, with the type of medication that we use, it's a daily dose. So it's really once a day. Most commonly, it's a once a day dose. So it's probably easier to attract compliance with something that's once a day than that you got to take 2 or 3 times a day. But yes, it does become a problem. And before we go into the surgical side, that'll probably be one of the reasons why it may happen that you require surgery.
Okay, so we'll come back to that. We need to take an ad break, inshallah, but after the ad break also the lines will be opened and the number is going to appear at the bottom of your screen, but I'll just read it out to you for now. 011 086 7701 or 2 or 3. 011 086 7701 or 2 or 3. So inshallah we'll see you after the break as we take the ad break now. Assalamu alaikum wa rahmatullah. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. We're discussing urology tonight. We're discussing the prostate gland, a common condition when it becomes enlarged in the male. And we have the benign element. We'll talk about the malignant element. We're waiting for your calls. The lines are open. 011 086 7701 or 2 or 3. 011 086 7701 or 2 or 3. Salim, before the calls come in, and inshallah they will, we were discussing the medical management of a prostate gland that's become enlarged in a non-malignant situation, benign. One of the things that we find is those drugs do have a bit of a side effect. Not too many side effects, but one of the more common ones and things that disturb them. Sometimes you even have to stop the drug.
That's right. With any drug that one takes, there's likely to be some side effect, and yes, we do see that also with the medical therapy for an enlarged prostate. The common side effects that that I hear in my practice are things like headaches and dizziness, because the medication is known to have some effect on the blood pressure. It can lower the blood pressure. So in lowering the blood pressure, one is likely to experience a bit of dizziness, maybe a headache, and something becomes so severe that the patients actually feel like they're actually going to pass out. Which can be quite significant, and then one has to, you have no option but to change the drug or stop the drug and use something else. But yes, those are the common side effects. There have been other reports of blocked nose, stuffy nose, decrease in the sort of ejaculate volume as well has been reported by some patients. But generally, I think the common ones are dizziness, headaches because of the drop in the blood pressure.
By and large, the patients cope with those side effects, generally.
Absolutely,
okay.
Absolutely.
All right. So now we've done the medical management. There are some surgical options to this particular condition.
Yes. So just in a nutshell, to summarize it, so in those patients where they've likely to been on medication for some time, and we notice that there's no real improvement in their symptoms, or it was improving and then it stops improving, and we realize there's no point in continuing with medical therapy, we will then offer them a surgical alternative. And I'm sure patients are familiar with the term scraping, because they often ask you, are you going to scrape my prostate?
That's right.
Yeah, and that's basically what it is. There's obviously a revolution, I think, in the way we manage conditions in the 21st century in the world.
It's much more simpler now.
Absolutely. I mean, there's so much of advancements in medical science that, and especially in urology, I mean, there's very, very few situations in urology where we actually have to make an incision or a cut, which we call an operation. We tend to say it's a procedure. It probably defines it a bit better. But yes, basically the procedure is done through the penis, through the private part. So you place a camera into the penis and you access the prostate in that way. And via that route, one is able to shave or resect those parts of the prostate that are causing a blockage.
Okay, and then obviously the post-op recovery is quicker because of procedure rather than operation.
That's right.
All right. We have our first caller. Assalamu alaikum.
Walaikum salam wa rahmatullahi wa barakatuh wa maghfirah. I just want to say...
Go ahead, brother.
Assalamu alaikum. I just want to say that Allah Ta'ala bless doctor. Alhamdulillah, he done an op on me and it was a very successful op, and we make dua that Allah use him as a means of shifa for everybody that he touches, inshallah. Jazakallah. Assalamu alaikum.
Jazakallah khair for the call, brother, and Ameen to your dua, and Salim, Allah grant you more healing in your hands in shifa, and may Allah bless you too, and the viewers who are all watching the program. So we'll continue until the next caller. So we're discussing the surgical. It's a simple procedure. The post-op recovery is pretty quick, and it's not a major procedure, as you say, eh?
That's right. I think the important thing is for the patient to be properly counseled. We need to, there's obviously a thin line between what we say operation and procedure. It's got to be done in theatre. It has to require anesthesia. So there are still potential complications. And we go through them. But clearly, for someone to have a cut on the abdominal wall, to have a prostate taken out, and for that person who has it done through the cameras and via the urethra or via the penis, one can obviously understand that there's going to be a huge difference in recovery. the person that has a procedure done from the inside is going to recover much better.
Okay. Jazakallah. Another caller. Assalamu alaikum wa rahmatullah.
Wa alaikum salam wa rahmatullah, and assalamu alaikum to the wonderful program and the doctors.
Wa alaikum salam.
And we really appreciate your sacrifices and the fact that you are coming to educate us. May Allah bless you.
Ameen.
I am 78 years old. I had a brachytherapy treatment in February. That is, and then after 3 months, what they told me that I am sort of 50% of the brachy has been, radium has worked in.
Mm-hmm.
Now what I want to know, do I have to go for a radium treatment in spite of that? That's question number one. Number two, at our age, I find that the doctor was trying to tell us about going out during the night to urinate. I found that if, for instance, that tea is the worst thing to have late at night about 10, 11. And if you cut off the tea about 7, and you may drink a little bit water, but then you have a peaceful sleep right up to the Fajr. I would like you some comments on that, please. I'll listen on the TV.
Jazakallah, brother, for the question. Good comments and good question. Brachytherapy, we were going to get onto that with our cancer treatment, am I right?
Yes.
So yeah, and then maybe we can get a slide also coming up.
Yes, yes.
Slide, which one do you want?
So the brachy slide, that's slide 3.
Okay, slide 3 will come up in it, but maybe you can answer the question.
Yeah, we'll bring it up later. Your question is whether you require radiation treatment in addition to the brachytherapy, if I understood him correctly.
Yeah.
So you've already had the brachytherapy. There is a place for where we use what they call external beam radiation. It's also radiation or radium, like you put it, but it's not brachytherapy where the seeds were placed into the prostate. It's not from the outside. In certain patients that have high risk disease, Yakub, basically yes, we do. They would have a combination treatment that would include things like perhaps hormonal therapy, including brachytherapy, and maybe even added to that external radiation or added radiation in addition to the brachytherapy.
Okay.
There is a place for that.
Okay. So to answer the question, the patient, the brother must go back to his urologist and explore the next option and consider it.
Yes. We didn't get too much of the specifics about the type of cancer he's got, but often that's a decision that's taken at the time of the initial treatment.
Okay.
When one does the brachytherapy, one would now be aware whether you're going to add to that external radiation or whether it's just going to be the brachytherapy, because the doses will differ. So that kind of decision had to have been taken already. And like Yakub suggested, I think you need to follow up with your specialist or whoever treated you, oncologist, whoever was involved, and they are likely to answer that question, I think, more better. The other comment you made about the caffeine.
It's a very valid one.
Very, very valid question. Point in there. Thank you for that. I think that's a very well-made point. Thank you.
Yes. We have another caller. Assalamu alaikum.
Wa alaikum salam.
Go ahead with your question, brother.
Brother, I'm Jazakallah for the wonderful program. Absolutely nice program. I am 50. And I have absolutely no problem, no symptoms at all, right?
Alhamdulillah.
Do you think I should go for a checkup as a routine, or should I not worry about it and just let it be? And the second question is, how do we prevent the prostate from enlarging? What kind of diet do we go on to? Jazakallah.
Very good questions, brother. In fact, that was one of the things we needed to bring up. Can we delay the enlargement of the prostate? And of course, the question is should he go for a screening and a general checkup in regard to this?
You're right. Thanks for that question, brother. You brought us up the next topic, which we're going to discuss anyway. What you're alluding to about whether you should go for a test at age 50 is what we call PSA screening. We were sort of talking a bit about it earlier on, Yakub. There's different guidelines and there's different opinions regarding PSA screening. I'll give you an example. In America, although there's so much of controversy regarding screening, but about 90% of physicians in America themselves practice PSA screening or practice screening. They will go for the PSA check themselves. So the guidelines that we follow is that from age 50, one should go for at least one check. So you have an assessment of your prostate and have at least a blood test, just to have a baseline. I wouldn't say that you need to have it repeated again yearly, but perhaps you may just need to see a urologist again at about the 30 or 53 and then 55, and then maybe yearly from then. The point I'm making here is that there's so much of information out there about PSA screening that I think it's best, it's individualized with you and your doctor. That's what I tell my patients, that look, can we agree on how we're going to do this, and we stick to that schedule. And we sort of, present the pros and the cons and the negatives and the positives about doing PSA screening. But you're right. There was a study done where they found that in about 18% of individuals with a normal PSA and a normal rectal examination, in other words, they had a prostate examination and it was normal, they still harbored foci, or they harbored a focus, or there was some presence of cancer in those prostates. So the answer is we don't really know. Maybe it's nice to have a baseline and then work from that. So that will be my answer to you. You know, speak to your physician, your GP, maybe establish a routine or a follow-up that you're going to be happy with and do that. But at 50, I would think, I would advise you to have some sort of baseline check. More so if you have a family history of prostate cancer or other cancers in your family, I think that would be even more significant to have some baseline check.
So the message is obviously once you hit the age of 50, it's advisable and it's prudent to do the checkups. Like you would check your blood pressure, sugar, other screening tests for other conditions that can come up at that age and then present themselves. The prostate is one of them.
Absolutely.
Right. And then we have another caller, but just quickly to answer that question in terms of prevention.
Yes. That's probably not really possible. The reason for it is because the growth of the prostate is very testosterone dependent. Hence, it's obviously only found in the male, the prostate. And the growth of the prostate is going to happen as you age. In other words, aging in an enlarged prostate is not an abnormality. It's a phenomenon of aging. We expect that. It's the abnormalities that occur during that process that we're concerned about. So unfortunately, unless we block your testosterone levels and shut it down, which doesn't make any clinical sense, the answer is simply we cannot do that. There's nothing that's medically or ethically acceptable to say that, no, let's just retard the growth of your prostate. Okay. I don't think there's any basis for that.
All right. And then he touched on a diet. There's no real diet thing that you know of, or do you?
No. There's been a lot of talk about using tomatoes and saw palmetto, and there's a lot of things that have been put out in the literature and in the internet as well. If you search, you'll find 100 home remedies about prostate. But
not proven.
Not proven. None of them have been tested scientifically and proven now.
Jazakallah khair. We have another caller. Assalamu alaikum.
Wa alaikum salam. How are you?
Alhamdulillah. Sorry for the delay.
No, it's fine. Jazakallah. I'd like to find out. I've got multiple sclerosis, and now I've got it for a good couple of years, but I've had a problem with the urine, and the doctors, even the urologist that I go to, say, I was using a catheter, and he says it's not necessary. So he was treating me without saying not to use it. And alhamdulillah, it was helping, but I'm finding it difficult again. But I was taking the tablet oxybutynin, and that controls it, but sometimes the need of going to toilet sometimes, and you're going and you're sitting and nothing is coming out. And it's carrying on like that for a while again. So I'm more worried now because Ramzan is coming and I don't want to have that problem carrying on, and it's nothing helping it right now. What would you suggest? I'll listen to it on here.
Jazakallah for your question, sister.
It's a very
good question.
Very good question.
Yeah. In a quality of life issue, yeah.
Absolutely. Inshallah ta'ala make it easy for you and give you shifa and strength to overcome those difficulties. Yes, sister, the point you raised about, I'm sorry, you broke up for a few seconds there, but what I understood what you said was that you were catheterizing and then she stopped catheterizing now and they're using just medication.
Oxybutynin.
Did you get it as well? Yes. Look, when you have multiple sclerosis, it's what we would term as a bladder where the nerve supply is affected. So as a result of that, you're not going to have that efficient contraction of the bladder muscle to expel the urine. Therefore, you are reliant on the use of catheters to manually evacuate or manually drain the urine out of the bladder so it stays empty. Now, we know that multiple sclerosis it's not just going to go away, and unfortunately, in my practice, most patients that have multiple sclerosis, in fact all patients, will require some sort of way of emptying the bladder. Using the oxybutynin, one must understand that what the oxybutynin is going to do is going to relax the bladder. So it's going to relax it even more, and that's also going to somehow affect the contractor or the ability of the muscles to contract to expel that urine. So we would use the oxybutynin in someone that is catheterizing simply because they are going to use a catheter to empty their bladder. The oxybutynin will be used in those situations where they get sudden contractions of the bladder muscle and that causes them to leak. So with the oxybutynin, because it relaxes the bladder muscle, you're unlikely to leak between the periods when you are using the catheter. As a female, it will be easier for you to catheterize yourself as compared to a male that got multiple sclerosis. And I would say to you that you should, inshallah, try and overcome that challenge or that difficulty to use the catheter, and rather empty your bladder in that way. You can do it every 3 hours, every 4 hours, and stay on the oxybutynin as well. But in this way, you would be drier, you won't leak, and the risk for infections and complications as a result of infections will be significantly reduced.
I hope that helps, sister. We have one more caller before we take our next break. Assalamu alaikum.
Assalamu alaikum. I've been using Euromax. Assalamu alaikum.
Go ahead, brother, we can hear you.
Thank you. I've been using Euromax for something like 2 years with very good results. What I need to know is, can I now stop? Will my situation revert to the old one, or do I have to continue with this all the time? And is it advisable to change, or must I continue with the same medication? Assalamu alaikum. I'll listen on the radio.
Jazakallah khair for your question. Salim,
Okay.
Euromax.
Yes, that's just one of the tablets we were talking about earlier on. It's a once daily dose, which is what you're taking. And like we spoke about Yakub, I mean, he's been on it now for 2 years.
Yeah,
we were just talking about the duration of treatment. And alhamdulillah, it seems like you're having a good response to the treatment. Now, what we do know is that these tablets are not going to cause any shrinkage to the prostate. So logically, one would have to say that if you had to stop it, you're somewhat likely to come back again. But I must tell you, in clinical practice, we do that sometimes. We say, okay, you've been in it for such a long time. Let's just see what happens if you stop it. And we see how that affects the quality of your life. And does it go back again? Does it revert back to what you were experiencing? And then you obviously will have to go back on the tablet. But most often than not, we find that it's unlikely that if you're going to stop the tablets now, that your prostate is now gone to a smaller size. If any, it has grown with size because you've aged as well. So it's unlikely that your symptoms are just going to simply disappear. You're most likely going to be dependent on that type of medication.
Yeah, the tablet actually doesn't shrink the prostate. That's the message. It just helps to assist the encroachment on the urethra, the pipe.
In the bladder neck, yes.
The bladder neck, so that it just eases the flow.
That's right.
And helps to control. But it doesn't do anything to the actual structure of the prostate that is growing as a natural thing.
Absolutely. And that's the reason why, sorry, Yakub, that's why you will find that one is likely to reach a point where the medical therapy won't work.
Yeah.
Because it will just stop working. Because the effect of the medication would no more would not be able to keep up with the growth of the prostate and the effect that's going to have on the flow.
Yeah. Assalamu alaikum. We're going to be taking our next ad break, and then we'll talk to you when we come back. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, a comprehensive chat. We are live, expecting your calls. We're discussing urology with Dr. Salim Choonara, private practitioner in urology in Johannesburg. The lines are 011 086 7701 or 203. Number appears at the bottom of your screen. We've had some excellent questions today, Salim.
Absolutely.
And just want to get back to that female catheter issue with the sister with the multiple sclerosis, because this is the real challenge. And I know that they find it a bit of a problem thinking they have to catheterize them, but that is at the moment the most practical solution, and it's easier in the female.
Right.
And today it's simpler, right? The catheter is a bit smaller.
Yes.
Maybe you can just expound on that a bit.
Yes, thank you. I'm glad we got back to that topic. It's a tough situation to overcome. It's a quality of life issue for a female, to have to catheterize. It's a very sensitive part of the body as well. But to the sister that called in and to all the other multiple sclerosis sufferers out there and those females that are having to catheterize themselves, absolutely, as Yakub mentioned, there's no doubt there's so much of advancements in the way the catheters are made now, the size, the material that's used, it's much more softer, it's so easier to handle. And the one thing I want to tell the sister is that, for you to catheterize yourself, the reason why I was making a reference to a male patient is because in a male, the urethra or the pipe of the urine is about 12 or 14 centimeters long, whereas in the female, it's about 3 centimeters. So you literally just need to overcome that distance, and the catheter is in the bladder, and it will allow the urine to be expelled. So you just need to prepare your mind, inshallah, to overcome that, and your quality of life is going to improve a lot. If you can empty your bladder, you're just doing it manually. That's what it is. And no one knows. Like I always tell my patients, you go into a bathroom, it's in your bag, it's in your handbag. You go into the toilet, you're closing the door. No one knows what you're doing really in there. You put the catheter in, you expel the urine, wash it, put it back, and that's the end of it. And inshallah, hopefully you'll overcome that.
Inshallah, Allah make it easy for all of you suffering from this condition. It's a big challenge, but if you can overcome it, may Allah make it easy for you.
Ameen.
We have another caller. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam. Sheikh, what do I need to go for?
Sorry, brother, can you repeat your question? Can you just put your TV a bit softer?
No, it might be down. It's down.
Okay, can you repeat your question? We can't hear your question.
Okay. That was
We lost you there. You got a bad line. Please do call in again, and we'll try and answer your question as best as possible. Salim, so we've discussed now, we've been moving on to, we've discussed the benign, we kind of touched on the malignant aspect of the prostate through the questions of coming. Do you want to perhaps just maybe summarize or
I think if we can bring up on slide 4, I wanted to just bring up about the issue about the biopsy.
The slide 4,
yes.
Okay.
I thought that's a nice way just to approach it and just to mention about the prostate biopsy. Now, the reason why I thought this slide is important because when we face with patients that, like we were giving that patient we were talking about earlier on with a large prostate, we said we don't know, is it cancerous, is it benign,
to
we
make
don't
the
know
differentiation.
That's right. So we've done a whole lot of tests and we've done a blood test and we'll talk about the blood test a little while. But let's say this patient has got a suspicion for prostate cancer. Remember, at that point, all it is a suspicion. We don't know for sure. So the only way we can know for certain is by doing a prostate biopsy. And that gets done, often it's done in theatre, so that the patient doesn't feel it. But there are people that do it under local as well. In my practice, we do it in theatre under anesthesia. And basically what we use an ultrasound probe, like you can see demonstrated there on the screen. There's a probe into the rectum. And in real time, we can see the prostate on the monitor. And with a special device, as you can see the right hand of that on that picture, using sort of needles to actually biopsy the prostate, to get some tissue from the prostate. And then all that gets sent away to the laboratory and is analyzed. And then we know for certainty whether there's cancer in the prostate, whether it's just a big prostate, nothing to be concerned about, or whether there's actually an infection that's probably in the prostate that caused the PSA or the blood test to appear elevated or to appear raised.
Okay, so that's a good methodology and an investigative procedure, a simple one, and obviously it can be of great benefit to the patients to differentiate between the different conditions.
That's right.
Assalamu alaikum, we have another caller.
Wa alaikum salam wa rahmatullah.
Your question, brother?
Yes, I just want to check. I get another pressure pain at the bottom, and my frequency, sometimes I go a lot and sometimes it's just normal. So to check what the problem is. I'll listen on there.
Okay.
So it's a question of frequency. And
from your voice, you didn't give us your age, but you sound like you probably would be about maybe 30, 40, somewhere there. I think relatively sort of middle age. We know that, look, the prostate, like we said, it's probably likely to trouble you at a later age, what we're talking about, where the enlargement is going to become bothersome. But it doesn't mean that young people are not affected by prostate problems. That brings on the topic of what we call prostatitis, or infection of the prostate or inflammation of the prostate. And in a younger person, that's more likely to be the case, an infective cause for your symptoms. So from what you're telling me, especially with the pressure you mentioned at the bottom and that frequency you wanting to go to the toilet, again, the recommendation, and I would suggest to you to go to your GP or go to your specialist and have your prostate checked out. They'll probably do a urine test as well and assess your prostate. And if you've got an infection, it requires antibiotic treatment, and it should resolve your symptoms. If there's anything more, then they will explore those options. But yes, it could. From what you're telling me, it sounds like it could be an infective cause for the symptoms.
all right, so the message is not to ignore it, to have it checked, because you're living with this symptoms. So don't just overlook it.
Right.
Another caller. Assalamu alaikum. Okay, while we're waiting for the caller, Salim, you were discussing. So
it was.
Oh, there you go.
I told you with the oxybutynin, but another doctor had asked me to take Vesicare, and I was taking that because he says no, something to do with the vagina, with like a small or something, and he had to sort that out for it to come right, and he did it, and it helped. But then after that, he put me on Vesicare. And but I was then also napkins to be safe, and up now I've been on napkins. But I've been taking this Vesicare, and then after that it was the bladder was emptying a lot, and I just didn't know how come. So actually that's why I stuck with oxybutynin. And now why I'm finding it difficult to use the catheter also is because of multiple sclerosis. On top of it, it damages the eyes, and my eyesight is not good at all either. So I'm like more on napkins.
Okay.
I don't know any other opinion that you could tell me, that I know what I can try.
So she's looking for other alternatives besides what she's tried, medical treatment. Obviously the catheter and then the eyesight issue is compounding the problem. And using napkins now.
Yeah.
And memory as well.
Sorry?
Like, I think with MS, it's so many things that are at it at the same time.
Ji. Okay, Salim?
Okay, is she still on air? Or is she
Are you still on air, sister?
No, take it off now.
No, wait. You want to ask a question?
Yeah.
Hold on, sister. Salim wants to ask.
What I want to ask you is that, are you able to urinate? Do you actually able to urinate for yourself? Does urine actually come out when you want it to come out?
Sometimes you feel like your bladder is so full and you need the toilet. When you go, nothing comes out.
Okay.
And then you used to go sit and then you need to go again. And maybe after the second or third time, then a little comes out.
But a little, but there's not, from the feeling that you had and what comes out is so little compared to how you felt like you wanted to go. Do you actually feel like you need to use the toilet? I mean, can you feel that sensation?
Yes.
Okay.
And sometimes I would actually feel, no, don't drink water, don't do all of this. And now with MS, I know I have to because the nerves are getting dry.
How often
but
do
the
you...
thing is,
sorry, sister. How often do you have to... How often do you get the feeling that you need to go to the toilet? And how often do you actually really go to the toilet? How often in the daytime?
It's like I would actually try and restrict it in so many ways because it's like, no, you don't want to get up and nothing is happening when you go to the toilet.
Yes. You see,
and it is something common with a lot of people because I myself didn't know much about multiple sclerosis and I got it for about 7 years. Yeah.
You see, the problem...
But napkins are still best used for me right now.
See, but what the napkins are doing is it's just preventing you from leaking outside of your clothing, am I right? It's just protecting, that's what it's doing. But remember, the napkin is on the outside. It's not going to be a means of draining your bladder. In other words, as your bladder is full because you're drinking water...
Now with namazes, I don't think about it with namaz and that's what I said, first catheter, and I said, okay, it's so easy, you can do it, but sometimes I even forget what I'm doing.
Yeah.
And sometimes if I put something in my hand or something, it's like so many things at the same time. So it's like I have no feeling sometimes in up to my wrist also. So you're going to do that and you're holding it and you don't know if you're going to mess somewhere and then you're in up, so many things at the same time.
Yeah. But the important point I want you to understand is that by wearing a nappy, you're not draining the bladder. All you are doing is, as the bladder fills up, whatever overflows is going to come out and leak and catch and come onto the nappy. The difference with the catheter, and this is why I'm trying to insist on that, is that it will allow your bladder to be empty. In other words, you put the catheter in, you'll keep it there till you drain the bladder completely empty. There'll be now not much left in the bladder for it to leak out, but you can still wear a pair just for park and napak, for salah like you mentioned. But you know, and the thing is, if you're having a problem with the eyesight, you may need to consider getting a help or someone to assist you. But I think the most effective way of emptying your bladder, unfortunately, is going to be via the catheter.
You have another comment. I hope that'll help you, sister, and I hope we can find more solutions for you in the future. But for now, the catheter seems to be the way to go, and I hope you can find some ease and some help, sister. Inshallah. Salam. We have another caller. Assalamu alaikum. Assalamu alaikum. Okay, Salim, we're going to be taking another ad break now, and then we'll be wrapping up after that. Time has gone by. So we'll just take another ad break in the meanwhile, and then after that we'll do a bit of a wrap up. Jazakallah for your calls. Okay, we perhaps can continue with the discussion because we're going to wrap up just now. Okay, all right. So that is obviously a real issue now, and then obviously with the multiple components of the disease, like a multi-system disease like multiple sclerosis, it impacts on the bladder, but on other things too. So it becomes a real issue, and you can do the maximum that you can.
Right. I think the sister...
we have another caller.
Assalamu alaikum.
Walaikum salam.
Mansoor speaking. I had a brachytherapy in December of last year. The PSA reading was 12.87, and I did a PSA in April. It went down to 3.77. But that was not the issue. What's happening is I'm finding that I've got infection of the urine, which has now cleared. But I also find that the left testis swells up and pains. Now, is there a link, or what should I take? Furthermore, between the anus and the penis, I'll get a pain like. It's like as if you're sitting on a saddle, and it gives you a pain.
Yes.
What is it all about? Why is that infection? Because I've had the infection from day one.
Right.
Jazakallah for the question, brother. We can listen to the answer on the air.
Okay, so to address the issue, let's just address your second component. You mentioned about the discomfort that you're experiencing between the anus and the, let's say, the scrotum. Anatomically, that would be where the prostate would be. You know, if you had to put your hand on somewhere outside, that would be where the prostate would be. And that's the area basically where we insert the needles. That's the site where the needles go into the prostate. So you obviously can experience some discomfort, although you mentioned it's now a good few months since your treatment. I think you're just experiencing the discomfort from the actual procedure itself. Remember, it is radiation nonetheless. As much as it's localized to the prostate, but the surrounding tissues can have some effect of the radiation, and one is likely to feel that.
And then obviously he seems to be having an infection.
Yes, it appears to be that way. It appears to be that way.
And he needs to consult.
He's asking about the relation between brachytherapy and the infection.
There's no relation.
There's probably no relation, but unless he's got a very large prostate to have started with, and he's not actually emptying the bladder, he didn't really give us an idea how he's urinating. But if he's not emptying the bladder well or properly, or you know, with efficiency, he's likely to get an infection. You know.
Okay, so he's going to need some kind of review. And
I think it will be better for you to see a urologist again and have another assessment. You know, you shouldn't be getting recurrent infections after brachytherapy. That's not the norm.
Okay. All right, so we've had a very interesting discussion tonight in urology and good questions coming through. And again, as always, we can never really cover all the topics. We'll try and come back with the same discipline, but expound on what we've done and continue, because there's so much to discuss. We thank you for all your questions, brothers and sisters, and especially for the multiple sclerosis sufferers. Allah grant you shifa and make it easy for you. And with the month of Ramadan coming, we wish you all well and hope that you have a healthy and spiritually, morally, physical healthy Ramadan. Salim, Jazakallah khair for coming, taking out your time. We always appreciate our doctors that come out here and volunteer their time. We will be discussing in Ramadan. We will be having our programs on a Sunday afternoon between 3:30 and 4:30. You can look out for Health Matters for the Sundays. Nothing this Sunday, but from the following Sunday we'll be continuing. And your final comment, Salim, Jazakallah khair for coming.
I would say to the males out there that, you know, the females that always worry about the male's health, but I think the males should also look at taking charge of their own health. And it's important in today's time to be conscious of your health and look after yourself in just generally looking after your health status.
Yes, and then of course also apologies to our females where we couldn't really address all your issues on incontinence. We did a lot on the male anatomy, but hopefully we'll address those issues. And down the line we'll be discussing pediatric urology also. So once again, Jazakallah khair. We wish you a good Ramadan from the Islamic Medical Association and from ITV, and hope to catch you on the Sunday afternoons. Assalamu alaikum wa rahmatullahi wa barakatuh.